All right, let's dive right into this explainer. Today, we're unraveling a massive modern medical mystery surrounding the pancreas. Now, historically, finding a cyst on the pancreas was incredibly rare. Usually, it was something doctors only stumbled upon during an autopsy. But today, we're actually facing something of an epidemic. We are suddenly finding these cysts everywhere, and it's literally turning everything we know about cancer prevention, patient anxiety, and when to intervene completely upside down. Take a look at this truly staggering statistic. Nearly 38% of people over the age of 80 have a cyst on their pancreas. I mean, we're not just talking about a fraction of a percent here, right? We're talking about well over a third of the elderly population just walking around with a pancreatic cyst. And it's not just the older crowd either. Right after age 50, the prevalence jumps to over 11%. So these aren't isolated one-off cases. This is a widespread, massive phenomenon. So, with advanced MRI scanners finding these things absolutely everywhere, we really have to ask ourselves, if they're so common, why are they so dangerous to misdiagnose? Well, the thing is, pancreatic cysts aren't just one single uniform disease. They're a really complex, heterogeneous group of lesions. Some are totally harmless, but others, they're literal ticking time bombs, precursors to pancreatic cancer. It's a huge deal because if a doctor misclassifies a benign cyst as dangerous, they might order life-altering unnecessary surgery. But if they misclassify a dangerous cyst as benign, they miss a fatal cancer. Here's how we'll break down this medical detective story today. First, the accidental epidemic. Then we'll meet the cystic suspects, profile the bad actors, check out the detective's toolkit, weigh surgery versus surveillance, and finally, look at the future of detection. Section 1. The accidental epidemic, a modern medical mystery. Let's look at how a historically rare finding blew up into a widespread phenomenon. So mainly because of incredible modern imaging, we're suddenly finding millions of tiny, mostly harmless cysts that we frankly never would have noticed before. There was this massive meta-analysis looking at over 65,000 participants, and it revealed an overall prevalence of up to 18%. What's happening is people are going in for MRIs for totally unrelated reasons, maybe back pain or a kidney issue, and boom, the radiologist accidentally spots a cyst on the pancreas. But here's the catch. The vast majority of these are under 1 centimeter and completely indolent, meaning they aren't causing any trouble at all. Moving to Section 2, cystic suspects and identifying lesions. To actually solve this mystery, doctors have to act like detectives and organize these discoveries into a sort of lineup. Let's look at the big 4 lesions here, basically separating the harmless alphabet soup from the really dangerous stuff. First up, we've got IPMNs. These are super common, making up to 82% of findings, but their cancer risk is all over the map. Then we have MCNs, which typically show up in middle-aged women and carry a 12 to 17% malignancy risk. On the completely harmless side of things, you've got SCNs. They make up about 30% of cysts, but their cancer risk is practically zero. And finally, SPNs. These are pretty rare, mostly found in young women, but they carry about a 16% risk of malignancy, so they almost always warrant removal. That brings us to Section 3, profiling the bad actors and the risk factors. Now that we know who's who, the crucial next step is figuring out exactly what causes these suspects to turn into cancer. Just like criminal profiling, doctors look for specific clues, and a lot of those are modifiable lifestyle factors that strongly correlate with a cyst turning malignant. Take heavy smoking, for instance. If a patient is a heavy smoker, these cysts tend to show up way earlier and have a much higher likelihood of transitioning into aggressive pancreatic cancer, or PDAC. Similarly, severe obesity, specifically talking about a BMI over 35 here, is definitively linked to a higher risk of the cyst harboring carcinoma. And of course, increasing age plays a massive role too, basically accelerating the risk across the board as we get older. But hey, on the flip side, many of these cysts are practically just innocent bystanders. In fact, these quote-unquote trivial cysts actually carry a lower cancer risk than the patient's age-matched general population. It's wild. Let's say a patient over 65 has a small branch duct IPMN that's just a cyst in the side branches of the pancreatic duct, and it hasn't grown in 5 years, 0 worsening features. The data tells us it's functionally harmless. In these very specific cases, doctors can actually just stop monitoring it entirely because the risk of it ever turning into cancer is literally lower than the baseline risk of an average person at that age. On to Section 4, the detective's toolkit and diagnostic methods. So how exactly do our medical detectives interrogate these tiny suspects?
Well, they rely on a highly advanced step-by-step toolkit ranging from high-definition internal ultrasounds all the way to next-generation molecular DNA testing. Step 1 is endoscopic ultrasound, or EUS, which lets them look incredibly closely at the walls of the cyst. If they see little growths inside, called mural nodules, that is a huge red flag. Next, they can actually draw fluid straight from the cyst. If the glucose level in there is extremely low, or if a specific protein marker called CEA is high, it points to a potentially dangerous mucin-producing cyst. And finally, the cutting-edge stuff, next-generation molecular sequencing. This actually allows doctors to look directly at the cyst DNA to hunt for early signs of cancer.
Section 5, Surgery versus Surveillance, the ultimate balance. This right here brings us to the ultimate Goldilocks paradigm, deciding whether to lock the suspect up or just put them on probation. Medical professionals are honestly walking a terrifying clinical tightrope every single day. They are desperately trying to balance the severe, life-altering harms of unnecessary pancreatic surgery against the fatal cost of missing a cancer. Think about it. If a doctor overtreats a benign cyst, they're subjecting the patient to a massive operation that carries a 2 to 4% mortality rate, even at the absolute top hospitals. Plus, it can leave the patient with permanent diabetes and severe digestive issues. But if they undertreat, they might just miss the only window they had to cure one of the most lethal cancers known to medicine. But just keeping these cysts on probation takes a massive psychological toll on the patient, too. It feels like a deadly weapon is constantly dangling right over their head. Just imagine sitting in an office and being told, hey, you have a cyst on your pancreas that might turn into a deadly cancer, but we aren't going to remove it yet. We'll just check it again in 6 months. Researchers actually call this the sword of Damocles effect. It leads to profound anxiety, depression, and severe stress, completely ruining the patient's daily quality of life while they just wait in this terrible medical limbo. And when you zoom out and look at the macroeconomics of this, performing routine preventative surgery is just wildly unsustainable. I mean, it costs an astonishing $3.6 million to find just one extra cancer compared to careful surveillance. It simply doesn't make sense. Routine surgery has incredibly low specificity, meaning we'd be operating on way too many healthy people just to find the sick ones. Risk-adapted surveillance, on the other hand, comes in at about $31,000. That is incredibly cost-effective, and more importantly, it spares thousands of patients from unnecessary physical harm. Which brings us to our final section, Section 6, the future of detection, AI, and precision medicine. Let's explore exactly how we're going to solve this massive healthcare challenge moving forward. Our medical detectives are getting a massive upgrade. Artificial intelligence is already stepping in and outperforming human experts in identifying the true bad actors from the harmless mimics. By feeding thousands of MRI scans and pathology reports into machine learning models, AI can now look at a cyst and accurately tell if it has high-grade dysplasia, which is the direct precursor to cancer, and it does this so much better than the human eye ever could. It easily distinguishes those dangerous mucinous lesions from the entirely harmless serous ones we talked about earlier. This is a total game changer, offering a future where diagnosis is fast, non-invasive, and incredibly precise. Which leaves us with this final provocative thought to wrap up our explainer today. As our AI and molecular tools become basically perfect, will patients finally be freed from the shadow of the sword of Damocles? We're moving from this chaotic era of accidental discovery and widespread anxiety straight into an era of true precision medicine. The ultimate goal here is to one day be able to tell a patient instantly and definitively, your cyst is totally harmless, go live your life. Or, your cyst is dangerous, let's cure it today. Thanks so much for diving into this fascinating medical mystery with me.